and supination of the foot. Just like this.
Cast.
It was originally designed to help treat MCL injuries and ankle injuries. That's a slocum. We don't do those anymore. Then they just do Quigley casts, which are original Quigley, to control the rotation, has to be a long leg cast. But now, with our surgical techniques as good as they are, we don't even do that anymore. We do a lot of short leg Quigleys, which to me is not a true Quigley. It's not worth stopping the knee from moving anymore and stopping the rotation on some of these things. If they're that active of a person, we're going to operate on them. If they're not that active, then we'll just put them in a short leg cast and let them be and not torture them to death. Okay? Now, you see at Kaiser, we do a ton of these things all day long with bulky Jones, short leg casts. The bulky Jones ones that we do, those are ones pending surgery. I totally disagree with how we treat those things. I don't like the fact that we postpone their surgery because of their swelling. And I understand if they have a cut or something like that, but statistics show, if you talk to some of our ankle guys, that we shouldn't be doing that.
And some of them are getting weekly checks, aren't they?
You get weekly checks.
So you might have to redo it.
Mm-hmm. So every week, we bring them back, change their bulky Jones, and re-wrench on their ankle. Now, sometimes we're also doing a Quigley, even though they have no syndesmotic problems whatsoever. We don't know if there's a syndesmosis problem, so we still do a mild Quigley cast. But a true Quigley maneuver is what I'm going to show you guys today. Did you do your nails? Toenails still done? I've been waiting all day to see these toenails. No stockinette. Why? Oh, they're redone. Oh, cute. The big thing is that the reason why I don't like to put stockinette on these is it is a true reduction maneuver. Now, granted, again, like I was telling you before, we are doing a lot of these that are just modified Quigleys, where they don't want us trying to like hurt the patient too much. I don't know. I think that's just hogwash. But I'm going to show you what we do for a true ankle fracture that needs to be reduced. And then if you have one where they're just trying, it's just like a prophylactic mold, then you can go ahead and put the stockinette on. A true Quigley cast would call for slight rotation and slight plantar flexion. So this would probably be how I would put that cast on, a true Quigley. Now, I put them in a little bit of supination. You're drawing the fibula out to length. Because if you think about it, if I compress it, the fibula is short. So I rotate it in, draw the fibula out to length. Okay? Then I'll also take and shove with the calcaneus. I shove it medially. Okay? At the same time, I counter my second point mold. Where's my third point? The knee. My head. And this is what I do. I put my head right up on their knee. I kid you not. This does not work. See, the harder I push, the more I just rotate her out. So it depends on how far back you really want to go with this. But again, a true Quigley cast should be a long leg because look, I need to control that rotation, right? But again, we don't do a whole lot of that just because of surgery. I don't even put any splints in this cast because I'm more concerned about the fracture reduction. Now, if it was wildly displaced, I would do the reduction right now just by simply holding them down I give them a little pull straight down, and then I shove it over medially, and you'll feel it and hear it clunk. Then you let it go, because then you got to wrap, right? And you will see as soon as you let it go, it's completely unstable. You'll grab your chair, you'll put your roll of web roll on.
You don't mess with it too much, it won't come back out.
No, they slowly migrate back out.
Okay.
They don't want to be there. So right here, I'll kind of bring her up, I'll rotate, I'll let her supinate a little bit. And you'll see that she'll start to go back to the the way you put her, if that makes sense. Pat it just like any other short leg cast that I do. Now I can do these casts all day long, maintaining 90 degrees. But I teach you a little bit of plantar flexion and a little bit of supination, because that's what a true Quigley is. Everything that I do is a little bit, what I do is a little bit modified. So I have to teach you the way the book tells you to do it versus the way that I just do it in general. My theory is I don't need the supination, because really what I'm trying to do is reduce the mortise and not necessarily reduce the fibula, if that makes sense. Let me get some gloves. A lot of times there could be somebody holding whenever you do this. For some reason when I do these, no one ever holds. The doctor never comes in and says, here, let me hold that for you. Or the PA. Does this have to have a toe plate?
No,
Thank God you guys said no. What? This is non-weight bearing. Toe plate's not just for weight bearing though. Toe plate is for metatarsal fractures or phalangeal fractures.
What's the pain level like for these guys?
Some are pretty bad. Some hurt a lot.
Do they do any type of...
Sometimes we do a hematoma block. Sometimes you'll see conscious sedation, depending on how bad the ankle fracture is. If it's dislocated out the back, those people are plantar flexed. And you have to dorsiflex them to reduce it. Two rolls. I'm kind of done. Still allowing her a little bit of supination, right? You guys, this is easy catch, you guys. This is your mistake all the time. Okay? Equinus, supination. So far, it's got your name written all over it, right?
Short leg cast.
Now you guys are all going to get perfect. So I got plenty of time before I actually do my mold. I also am going to hold a little bit of internal rotation. Remember, that's what you're trying to hold. Internal rotation. Here's my mold right here. I come up, I do my third point. Now I firmly agree I don't need the supination. and the plantar flexion. I think I could do the whole thing without that, and I've proven it time and time again. But I will say this, when I'm in surgery and I'm operating on these guys, and the doctor's trying to get the ankle back, or the distal fibula to line back up so he can put a plate on it, a good assistant puts them in this position. So again, it kind of contradicts each other here. I'm showing you guys what the book says, but we're not doing the long leg. And why am I putting my head up here if there's no third point mold in the cast? Exactly. So if I do this, I'm trying to do this. So I don't have to close over here.
Is there a special point on the tibia that you're going for, or is it just kind of
Just above your, it's just the second point. So obviously not on the fracture, not on the ankle itself.
You want to stay like below the meaty part of the calf?
Yep. You want the meat.
You want the meat?
Well, you don't want way up here.
That's what I mean, like right at the base of it, kind of?
Well, if you think about it, what are you trying to do? Try to shove the mortise over.
Mm-hmm.
So you tell me, whenever you guys put your ankles back in place, where is going to be the best part? If I shove this way, how do I fight it?
Yeah.
Can't fight it lower, then you cause a problem.
It's the most stable point.
Chris, where exactly are you holding with your right hand?
I'm on the calcaneus.
Okay.
Any of that hurt you?
Just at the end where you're pushing pretty hard.
When I put my head up there?
Yeah. So without one that's displaced pretty bad, what will we feel? Anything?
Oh, you might feel a lot of crepitus.
Crepitus?
Lots of crepitus. What's crepitus?
Cracking, crunching.
Yep, we talked, remember last time when we talked about reductions, crepitus should be in your vocabulary.
Mm-hmm.
A lot of crunching. You might feel a clunk, depending if it's subluxed or not.
Mm-hmm.
The only difference I would do any different between this and one where it was posteriorly subluxed is I do the exact same maneuver, except bring the foot way up into dorsiflexion. That's how you're going to hold that in place. And you may have to, instead of when you pull down, pull forward a little bit with the heel. Pull down, forward, and then your maneuver. Way up, dorsiflexion. You can still supinate. Because of the level of fractures, you can have slightly variations on how you do it. But remember, if you over-reduce a fracture, it's very rare to over-reduce a fracture, number one. Number two, if you do that, it's a sign of surgery anyhow, if the patient needs surgery. So my thing is I always try harder than they need to. And then go from there. And you guys all know how to cut these out, right? Short leg cast.
Not much of a
No
mold
toe
over
plate. No, there's a big mold there.
there.
Would you roll fiberglass over this?
We do.
That's right.
We do.
Yeah, right.
We absolutely do. I do this cast in fiberglass and no plaster at all. It just really depends on the patient, what I'm trying to do. If I was doing this in the emergency room, this is what I would do. If I was doing this in the clinic, where I'm trying to hold a mortise from maybe being in or out
Then
for
you go
4 weeks while a 90-year-old lady is trying to heal, then I'll do it in fiberglass. You see what I'm saying?
Yep.
Or a 400-pounder that is obviously not going to stop putting their foot down. You're going to have to be your own judge on that. These people are going to come back with a cast ripped in half, or in severe pain. What's going to be? What method do you want to see these people come back? Let's see what you guys need. Quigley cast. Any questions first? Some of you guys have been putting these molds in already, right?
Mm-hmm.
Hang on, yeah.
Should be done fairly quickly. Sorry? Slight internal rotation. Now, when you take, because we're not doing knee, you won't be able to hold internal rotation.